Well, hello, everyone. We're very happy that you could join us tonight for this webinar with Dr. Hagi. I want to start by thanking Dr. Hagi to be with us tonight and being so kind as to talk about his experience about measuring bite force and how he's using our technology, the InnoBite, to do so. Dr. Hagi has been using our product for, I believe, over a year now. And so he's going to be able to tell you a lot about it. So let's just talk a little bit about how this webinar is going to work tonight. First off, we're going to be sending you to all the attendees that are answering the poll questions, your CE credit and certificate soon after the webinar. So you should expect that by email. In the webinar, we always ask everyone to ask as many questions as possible. You can either write them in the Q&A just by pressing Q&A at the bottom of your screen, or you can write them in the chat directly. And at the end, Dr. Hagi, Marianne, and I are going to have fun answering your questions. Without further ado, I'm going to also quickly thank our partners here tonight, one of which is Endow Medical, to make this webinar happen. And again, Dr. Hagi, thank you so much for being here tonight.
Thank you, Frederic and Marianne. I'm grateful to be here and share this information with everyone. I know everyone probably had a long and busy day at work, and it's great to sit down, relax, and listen to some new information. A lot of these things about occlusion and the bite, a lot of you are aware of. A lot of it is going to be new. And like Fred said, any questions at all at the end related to the InnoBite device or any other questions that you may have, I'm going to welcome them. So first, I'm going to give you a few disclosures. I practice in Thornhill, Ontario, and I consult for various implant companies like Straumann, Carestream. I do these lectures. I don't directly get compensated for sales of products and things like that. I do these things because I like some of these materials. I like to share the knowledge. I also run an education company for dental implants and rehabilitations. So that's part of my daily practice as well. So let me start by showing you sort of what my day in the office looks like. So. Practice and my days are very similar. I do a lot of implant treatments, and I try to stay ahead in terms of what's available in dentistry. And my cases, of course, are sometimes big rehabilitations. And I use titanium implants for a lot of things, and I use ceramics for a lot of other rehabilitations. And these questions about occlusion, the bite, breakage, and the longevity of our work always come up with patients. And this is why I always look for new and innovative materials, techniques, instruments to try and enhance the patient experience, to try to enhance our outcomes. So something like this, which we did 8 years ago in terms of a fully guided surgery, was one of the first in sequence cases done in Canada. using the latest technology that a lot of you may be aware of is out there, but we've been doing these things for a long time, and equally using these ceramic implants, which are new to most of the profession, but I've been using them for about 10 years, really successfully for rehabilitating partially edentulous patients and even fully edentulous arches with these types of implants. And again, when we're doing implant treatments, when we're looking at these very large rehabilitations, occlusion plays a big role in all of these rehabilitations. So let me ask a question to the audience. How many edentulous patients you think in your practices refuse implants each week? And you can dial in your answers. I know Marianne is there tallying this up. So if you can answer that, and then Marianne is going to give me an idea of how many. And I realize that some practices don't really see a lot of edentulous arches. Depends where you practice. It's sometimes a geographic thing, and sometimes a demographic of the practice. If you see a lot of younger patients, you might not see a lot of patients with terminal dentitions or dentures that are ready to transition. I see quite a large number of these terminal dentitions. And I just wanted to get an idea of how you guys do. So Marianne, do we have some numbers?
Sure, I'll go ahead and end the poll, and then I'm going to go ahead and launch the results and share them. So about 66% of people response are seeing some that refuse.
Okay, so that's a good indication, sort of, that we see some patients that need implants that don't want it. And of course, we have a lot of reasons why our patients don't want implants. Cost is always a reason that patients give us. I mean, implants are not the least expensive option that is available. However, our patients spend money on a lot of things. They just choose not to rehabilitate with that. And sometimes we need something to motivate them. So I'm going to quickly touch on that later on about how the InnoBite can help with that. But let's kind of go through what this presentation is going to be about, where I'm going to start talking about sort of the occlusal philosophy, or what is occlusion to me in a practical sense. I'm then going to jump from that to looking at why bite force becomes important in a practice, both from explaining the need for treatment to the patients, as well as making some decisions about treatment from a clinical perspective. And then I'm going to talk about how we measure bite force. And the InnoBite is a unique instrument on the market. There is really nothing like it out there. And this is why it's actually been a bit more than a year, Fred, that I've been using it. And it's been kind of eye-opening, both to me and the patients, when you actually get to quantify objectively something that we may have been telling them for a long time. So then that's going to kind of tranject to me showing you how I use this bite force determination in my own practice. And I'll share a case and then something that I finished today, just to show you sort of how I use it. So in dentistry, we tend to treat three diseases, right? The first one is bacterial, and we all treat that every day. We have caries, we have endodontics, we have perio. We're used to treating that. And then we have the cosmetic disease. Patients coming in, they don't like the shape, the look of their teeth, their position of their teeth. We have replacement of teeth, we have orthodontics, we have implants, we have aesthetic treatments that we can treat this disease. I find that the one part of dentistry that is often least looked at, especially in a general practice, is occlusal disease, or the amount of force or mechanical stress that's placed on the teeth. And we have different ways of treating this. We have prosthodontics and full mouth rehabilitations and orthodontics, and then implants to replace missing teeth, to reestablish the occlusion. So we have these three aspects of dentistry that interplay with one another. And each one of these affects the other. Like you can't treat caries in the anterior without looking at aesthetics and cosmetics. You can't put a crown on a tooth without understanding what the occlusion is going to be like. And you can't select materials for any of these things without understanding what the forces in the mouth are going to do to those materials. So occlusion, how the jaws come together, becomes really important. So I kind of said it, but what is the definition of occlusion? And really, in the dental context, it's really how the upper and the lower teeth come together, right? And upper and lower teeth come together when we're chewing, when we're swallowing, to some degree when we're speaking, and then when we're clenching and grinding and producing parafunctional forces. The funny thing is we put so much attention to the occlusal contacts between teeth to realize that our teeth only really touch one another during normal function during the day for about 12 to 15 minutes. And what I mean by that is that most of the contact between our natural teeth happens when we swallow. When you swallow, your jaws come together and you have this very light touch of the teeth. That's most of the contact tooth to tooth that should be happening in your day. When you chew your food, there's a bolus of food between your teeth. The teeth don't really bang together, right? It's a rare occurrence. It happens, but that's not normal function. So teeth coming together is not happening the majority of the day, but we spend so much time kind of refining occlusion, tap, tap, tap. Let's see where it hits. Let's see where the prematurity is, where in fact, it's not really where we should be concentrating on most of the time, because most of the stress, most of the biomechanical issues that happen are during parafunction, and it's at night. It's when your patients sort of come in, sit in your chair, and you can see their masseters kind of clenching up. This is where most of these stresses are coming from. So to me, occlusion is not just what happens when you're just tapping your teeth and how the teeth are coming together when I'm placing the restoration or when I'm rehabilitating, but it's controlling all the other things that could be destroying their teeth. And in terms of philosophies out there for occlusion, we basically have two overriding philosophies, and it depends what school of thought you've been raised with. We have something that's joint-based, which looks at centric relation and how the position of the joints affects the position of the teeth. And then you have the neuromuscular approach, or the muscular-based approaches, which say that your occlusion is more dictated by the position of the muscles, or the tension in the muscles themselves. Which one is right and which one you follow doesn't really matter, right? My approach, or my teachings of the past have mostly been joint-based. So this is the Dawson, the Coy, Spear, those schools of thought, whereas the muscle-based one are more based on the LVI and the neuromuscular approaches. What's more important to me is to understand the conformative approach or the reorganized approach. And to me, this means, when do we need to change what's there, and when do we need to keep what's there and just adapt our materials, our restoration to what is existing, right? So in a case like this, where somebody has most of their teeth in place, everything is stable, we are conforming. We are going to create a restoration that's going to fit into the framework that already exists. When we have a situation like this, where we're missing teeth, we have nowhere to start. We don't know what we're fitting into what. Here, we need to reorganize the bite. We need to create a new occlusion, essentially. And this is where the complexity starts, is that where do we place this occlusion, right? What's the philosophy that you're following to place an occlusion? And for me, this really comes down to a joint position. And this is where we look at a joint position, which is a centric relational position, which is a position of the joint in the most superior, posterior position in the fossa, versus a centric occlusion where most of your teeth touch, right? So where you're chewing your food, where you're functioning, that's your centric occlusion or maximum intercuspation position. and your centric relation position is a joint position, unrelated to the teeth. And what this image here is showing is sometimes there is a discrepancy between the two, and that discrepancy can put stress on certain areas of the dentition that could lead to some issues. Like I said, to me, the most important part is deciding whether we are going to rehabilitate something conforming to their existing occlusion or reorganizing it. And I have these ground rules that I'm going to share with you when I do which. Okay, so these are kind of the take-home messages for occlusion for me, and they've always been. When you have a fully dentate, asymptomatic patient and you're not changing the VDO, you use their existing scheme. So you use maximum intercuspation. Wherever they're biting now, that's where you're going to fit your MOD resin or crown or veneer or whatever you're doing, you're going to fit the occlusion into that. Now, if you have a patient that is edentulous, you have no references. You have to use a position that you can reproduce. And this is where CR comes into play. So centric relation, I can manipulate a patient into the most posterior superior position, and I can repeatedly go back into that position so that I can follow the steps of the rehabilitation. If you come from a neuromuscular approach, you can tense the patient, you can get them to a position where the muscles are most relaxed, and that's your reproducible position. It's a position that you can repeat and verify in one step of the rehabilitation to another. So these are clear. Now, if you're partially edentulous, and again, I'm looking at it from a joint perspective, if my centric relation and my maximum intercuspation position is not the same, so I have a discrepancy between the two, but they're comfortable in the maximum intercuspation, right? So I have no issues. They might be a little bit off. I can guide them into CR, but there's no wear on their teeth. They don't have clicking. They don't have pain, and they're pretty stable. I will not change their whole occlusion. I will use their existing position. Now, if their centric relation, their joint position is equal to the tooth position, and the tooth position again is reproducible, I'm going to use that tooth position. Whenever I can, I'm going to try not to change things. Now, if their centric relation and their intercuspation position is not equal, and you're not very stable, so they're sliding around, you don't have stability of the bite. Like, you could tell that these patients have worn down their teeth, they're having issues. At that point, you need to figure out how to get them to a more stable, reproducible position. So then I'll use centric relation. Doesn't mean I need to reorganize their whole bite. Sometimes it's an equilibration, sometimes it's adding material on several teeth, but I'm trying to use a reproducible position that I can create stability in their occlusion. And that happens in a few cases, it's not the majority. And then in the same way, when you don't have stability, when you don't have posterior teeth, you need to sort of go back to the centric relation. And because you need a reproducible position, if patients are missing all their posterior teeth, they can't bite in a reproducible position. It's always a little bit different. And that's when we'll use the centric relation to be able to give them a more stable occlusion. All of the occlusions that we build in to non-removable teeth tend to need some protection. And that protection comes from the anterior guidance. So your back teeth only should touch when you're in centric occlusion. So when you're biting down, straight down, you have contact on the back teeth. Once you start to move around, the front teeth disengage the back teeth. And that disengagement lowers the amount of force that's being generated by the jaws. And this is where the introduction into force mechanics comes from, is that everything about the bite, everything about occlusion, we are trying to minimize forces on the teeth, right? You don't need high forces. High forces tend to be more damaging. So everything that we do, we try to limit high forces, limit lateral forces, forces that can break the materials or the teeth that we have in function. And this is really an illustration of how canine or anterior guidance works. You have lines on the front teeth where the lower jaw slides, and you have point contacts on the posterior teeth. So this is a great segue into bite force. Why do we care about bite force? And at the beginning, I didn't think that bite force, I didn't really know much about bite force. To me, bite force was, it's more in the back of the jaw, less in the front. If I take a pencil and I put it on my molars, I can crush the pencil. If I put it in the front, I can't do anything. Like, this is really my understanding of bite force at the beginning. Then as you get into more reconstructions and use materials, we start to see fractures of materials. We start to see more fractures of teeth the more we practice. And we realize that there are things that are going on in some patients that, that might be attributed to bite force. And at the same time, we have patients that have zero bite force. Like, we have patients in dentures that really can't really chew anything, can't bite through anything. So bite force becomes a very important part of the discussion in terms of rehabilitation. But before I met Fred and the InnoBite device, we take it for granted, right? We see a patient that's worn down their teeth, and we assume, oh, wow, they're grinding their teeth. We don't really think about, could their force, the force that their muscles are producing, be higher than the patient next to them that has no wear on their teeth? And this is the answers that I was sort of looking for with the InnoBite device. And it's a deadly simple device. It's a mouthpiece. You put it in their mouth, they squeeze on it, you get the maximum bite force that they can produce. And it's very visual for the patient to understand. So from my perspective, again, I can look at a patient, I can say, you know, look at the size of their masseters, look at the wear on their teeth. I know that they're a clencher and they produce a lot of force, but they don't see it. They have to believe me. Now, I take this device, I show them, listen, a normal bite force is somewhere between 600 and 1,000 newtons. Let's see where you are. I think you're going to be really high. They bite down on it, they look at it, they're like, doc, what does 1350 or 1370 mean? It's like, this is why your teeth are wearing down. We need to maybe do something about it. Here are some of the options, right? And this starts a conversation. So how do I use it in practice? Sometimes when we see a patient that has potentially a high bite force, during the new patient exam, we'll take a bite force. This is part of the record keeping. How strong is your bite? And that's going to lead to a conversation about either a night guard, or, as we're going to see later on, material selection, or the number of implants that we're going to use. It's going to potentially change the treatment plan. This is why I really, really like the way, or the ease of how to incorporate this into sort of everyday practice. I think next is sort of a small promo video that I found, just kind of talks about the InnoBite from sort of a commercial thing. I'm not here to sell these to you, but I'm just showing you how simple the actual use of it is, because it really takes a few seconds to get a reading on a patient for this. And I'll show you these graphics and the charts of what they mean and how to present it to the patient in terms of quantifying it. So let's take a look. The mouthpiece itself is soft. Patients don't really mind biting down on it. It's easy to use. We apply it on our full mouth rehabilitations, on our implant cases, even on seeing how the bite force is after we insert protective guards. The scale is interesting, at least the values of where we are. We can go from 0 to 100. where there's deficiency, sort of anything below 600 to me, there's some deficiency in the amount of force. And usually you see that with patients that are missing teeth or patients that are in incomplete dentures that can't produce sufficient force. A normal biting force about 650 to 1,000 newtons. And then anything over 1,000 newtons, we consider it to be excessive or too much force is being applied. And then again, this is coming from the company about what are the meanings of these numbers. So excessive force, in terms of daily eating, you can eat anything you want. You produce enough force to crack through anything. When you have a deficiency, you might have a problem in chewing certain things or maintaining the articulation against something that's harder. When you have a significant deficit, you can't get through certain foods, so you tend to choose foods that are softer. So you're not going to go and chew down on raw carrots because that's going to tire you out. You're going to choose soft bread or maybe toast with jam rather than going for raw vegetables. So these force levels do affect our daily lives. We don't even understand it. We just make these subconscious choices based on how these forces relate to us. And then again, when you have critical deficiency, you can't even use prosthesis. You can't really eat. So here's another poll question I'm going to ask you, but do you think that measuring bite force would have an impact on the acceptance of your treatment plans, regardless of whether they're implant based or just general crown and bridge or night guards? What do you think this would, what would be the impact on the acceptance of these treatments if you could show the patients their bite force? So again, you can put your answer in the poll. We'll do this rather quickly. It's not a you don't need to think about it too much, and then we'll get Marianne to share the audience's sort of feedback as to how the impact would be. So overwhelmingly, we see that measuring the bite force would affect case acceptance, and I 100% agree with that. I think we would be far missed to say that that having the patient understand objectively what the bite force is would not get them to want to change it. And it's the biggest impact that I saw, at least initially in my practice, was for the protective appliances, for the night guards, because that's an easy solution. It doesn't change what their occlusion is, but it's just protecting it from further damage. So they realize that, hey, my teeth are wearing down, but a lot of the explanations, and we hear it every day, oh, my dentist, I had a little chip here and they filed it down. The dentist filed out the teeth too much, and that's why my teeth are all worn down. And you come to and you explain it to them that, no, it's not the dentist that filed, your last dentist that filed down your tooth, but it's you wearing your teeth away. Your teeth are getting shorter because you're wearing them away and they're getting closer together. But why? But why? But why? And now I have a way of showing them, look, most of my patients have a normal bite force. Yours is excessive. This is what's happening here. We need to protect it. Otherwise, you're going to be left with nothing. So this is an easy segue for the sort of them accepting a night guard. But at the same time, this conversation from bite force, and you'll see the cases, at least two of the cases I'm going to show you, it segues easily into rehabilitating their occlusion, because maybe they don't have anterior guidance. Maybe their anterior guidance has been worn down, and without reestablishing that, they're putting a lot of pressure on the back teeth, causing fractures, causing issues on the rest of their bite. So now we're looking at, because of your excessive bite force, we don't have anterior guidance. We need to reestablish that as well. So it segues into other aspects of dentistry. Maybe you don't provide that in your practice, but it opens up for them to be able to to get to a healthy state as far as their teeth as well as their bite. So moving right on, in private practice, each one of us sees this a lot, and it's a broken tooth, broken restoration, and bite force may have a connection with this, but we tend to almost instinctively blame it on material failure, right? Because we don't look at bite force, really. We never had a way to look at it. So we blame these fractures on materials. Like we had Empress, we had Empress 2, and these materials are not strong enough. We put composite resin, this material is not strong enough. We take it in isolation as like a whole, these materials are no good, but maybe these materials are not good in certain situations. So to highlight this bias, I kind of want to talk about this interesting phenomenon. So this story comes from World War II. Airplanes were coming back from the battlefield, and as they were landing back, the damage that these airplanes were taking from the German anti-aircraft guns was analyzed. And the planes came back with damage in these areas, so that the wings, the tail, and the fuselage, some parts of the fuselage. So the engineers at the time said, okay, listen, these are the areas that are getting damaged. We should really reinforce these areas. We should put more steel. We should thicken those areas up to make them more resistant, right? So there's less damage on these parts. And the interesting part is that Abraham Wald came in and he said, hold on a second. We're not looking at the right thing here, because these planes that are coming back have this damage. But in reality, the planes that we're not seeing coming back are the ones that suffer damage where we don't see these bullet holes. So the ones that get hit in the engines or in the cockpit or on the rear part of the fuselage, those are the ones that we're not seeing back. And those are the ones that are getting shot down, right? Maybe we should rethink it, and we should be reinforcing these parts of the plane, right? Because we're not seeing these back, but maybe these are the weak parts that are killing our pilots and destroying our planes. And this is the survivorship bias, right? And this is what we do every single day in practice, is that we blame things on the wrong cause, and we need to look deeper into what's happening. So this is the first case that I'm going to show you. Is a patient of mine. This is an older case. About now we're going back about a year and a bit, not that old, but I mean, he's a young guy, so it's an old case for him, because when we did this case, he was about 32 years old. But look how much wear on his teeth. Look how there's matching wear pattern on this occlusion. For a young guy like that, you know that he's going to have nothing left by the time he's in his late 40s into his 50s. And we measured his bite force. It was 1470, which was actually one of the highest bite forces that I've measured in the ever using this InnoBite device. And it was incredible, like to show him this, to show him how strong his bite force was, and comparing him to other patients. He really understood that there's something wrong with his teeth, right? There's something wrong with him. And he was gung-ho about rebuilding it. You could see this is somebody that had like almost zero history of any other problems, right? Like a few fillings here and there. He had a fracture of a molar on the upper left side, but really minimally restored. Yet he was going to go ahead and rebuild his bite, rebuild his anterior guidance. Now, here's the interesting thing. When we put a guard in his mouth, again, I told you I can measure the bite force. The bite force went down to 870 from 1470. And how do you explain that 45% reduction in force? What I usually see now is that because of the thickness of the guard and the lengthening of the muscle, we do see a reduction in the bite force. And I've sort of looked at a lot of data over the last year, and we do definitely see this reduction in bite force with these occlusal appliances. Is that what I'm necessarily looking for? No, I'm just looking for a plane to protect against the grinding. But there appears to be a reduction in bite force just by sort of adding that thickness interocclusally. But for this guy, what we ended up doing is we ended up doing a full mouth reconstruction on him, rehabilitating his vertical dimension that he lost through wearing down on his teeth, and really changed his life in many ways. And this is obviously, he still has a very high bite force. We didn't change that, but he's a lifetime in a night guard. And this is how he's going to spend the rest of his days, right? Until he breaks something at some point. This is another case which I actually inserted today. So I kind of added this on to the presentation, and it's an interesting takeaway from this one. Older lady wore down her teeth severely. Obviously parafunction, deep bite. She had gone through orthodontic treatment, some implants, but her initial InnoBite reading was 840, and this really puzzled me. And you ask me why? Because I've had experience with a higher one, and he didn't have almost as much damage. I mean, she was older. So why is this number looking normal compared to Greg, who had a much higher number? And what I realized with the InnoBite device is that it really depends on your complement of teeth. So for this lady, and this is sort of in the midst of treatment that I'm measuring this this number. She was missing her teeth. Like, she was missing molars on the right side. She was missing the 1-4. At the time, she was missing some teeth on the left side. So she has less teeth to produce that force. So our InnoBite number is lower. If we have a full complement of teeth on her, I'd expect the number to be higher. So these numbers have to be sort of analyzed as to what their true meaning is. And so at the end of this type of rehabilitation, when I'm rebuilding her occlusion and I'm adding more teeth into it, I expect that number to rise, right? Because now I have more occluding surfaces against that sensor, which has a fluid inside of it. So it kind of senses how much pressure or compression there is against that fluid. And as a result, the more complete your dentition is, the higher the number is going to be. So you have to be cognizant of that, because if you're measuring a worn down dentition, but it's not a complete dentition, your numbers are going to be somewhat lower. So for her, we rehabilitated everything. This was the final rehabilitation. You'll notice that I put back most of her teeth. She's still missing 2 molars on the right side. But now her bite force measured almost at 1200 when we measured it today. So you could see a stark increase because we added about 30% in terms of occluding surfaces to her dentition. And in this situation, kind of looking at the InnoBite as a help, did that help me sell the case? No, I don't think the InnoBite had anything to do with that in this case. But what the InnoBite does have is on the night guard in this case, right? Because she said to me at the end, when we inserted everything, she goes to me, but you fixed everything. Now you talked about this guidance, you talked about all these things. Why do I need a night guard now? And now I have a perfect set of teeth. You told me these materials are really, really strong. You can't break them on a table with a hammer if you banged it. I was using zirconia. Why do I need a night guard? And I explained to her, your bite force is still high. This is the measurement of it. You need protection. I can't control what you're going to do. So the mindset into them understanding what the objective measurements of the bite is really, really incredible. So this is the majority of what I wanted to go over, but I really wanted to touch base on sort of my theory about case acceptance, because a lot of you are going to ask, how does this affect case acceptance, or what really is case acceptance? So I'll give you my take on it, my take of private practice case acceptance in the last 16 years of my experiences, and how we got to this point. So case acceptance is, you can look at it as a game with the patient. And what I mean by that is, every interaction the patient has with your practice, you either gain or lose points in this game. It starts off neutral, right? The patient has a problem, right? They don't know whether they're going to pursue treatment with you or not, right? Every interaction, you either gain points or lose points. So let's look at the pathway towards case acceptance. And it starts off with how they got introduced to the practice, for example. So here we have somebody that has a broken, non-restorable tooth. They need an implant, or they have a tooth that broke. They get referred to your practice through a family member. Automatically, you gain points. Somebody that trusts you referred them. They have trust through that individual. You are in the positive now. They call the practice, and your front desk are polite. They're accommodating. They're answering all the questions. But all of a sudden, you don't have an appointment available Monday morning at 8 o'clock because that's when they have time. You lose points for that, right? In their mind, it's like, oh my God, they couldn't accommodate me. You lose some points. You were ahead, but now you're back to neutrality. So you book them in, they walk into your office and they see this is old, like there's nothing, it doesn't feel new, it's dirty. Look, there's a napkin on the floor there. The walls aren't painted. It gives them a bad feeling, and that you lose points at that mark. And if you have advanced technology, an office that shows cleanliness, that shows advancement, that you gain points with that. And the same as the doctor interaction. If I walk into a room and I'm condescending to them, I'm not listening to them, I'm not asking them questions, I'm not listening to what they want, I lose points. But, you know, it's me walking into the room, so I always gain points with them. Walk in, I'm asking them the questions, we get to understanding the problem, and then I give them the diagnosis. You lose points right away because all they hear is, oh my God, this is going to cost me a lot of money. To get the diagnosis, for them to understand it and to own the diagnosis, the more tools you have that are objective, the more help that is. So things, I mean, I'm here talking about the InnoBite, but being able to show them this is your bite force is a huge thing. New technology that's coming out, like CBCT imaging, second opinions through artificial intelligence on these images. All of these things bring up your point value in something that is a loss, right? The diagnosis is not something that a patient usually wants to hear. But the next thing is, and those are the options. Giving a patient options to treat them is what they're there for. And the more innovative, unique options you can give them, the more points you get. So what I mean by that is, let's say they walk in for a non-restorable, or so for a tooth that just broke. They went to another practice, and that practice told them, hey, yeah, that tooth, it's broken, it needs a crown, right? They hear a crown, you know, 3 practices tell them they need a crown. But they walk into your practice and you tell them, you know, that tooth, it's broken, but you don't have a lot of tooth structure there, and it would be a shame to cut it down and crown it. We can do a conservative bonded onlay on that tooth. And they're like, what? How come the other 3 practices never told me about a conservative bonded onlay on that tooth? All of a sudden, you gain points by being unique, by being different than what everybody else is. And for me, in my position, we talk about implants, and everybody else told them you need a metal implant, you need 6 or 7 or 8 implants to rehabilitate your maxilla. They walk in here and I can talk to them about ceramic implants. I can talk to them about more conservative approaches with immediate function. And all these options really give them more points, and you're getting closer to them accepting the treatment. You need to be more positive. You need to be as positive as you can before you hit them with a financial plan. because the financial plan is going to rock you back to the bottom, right? They're always going to take a bad stance because it's always going to be more than they expected, and nobody wants to spend money on these things. But as long as you were in the positive getting there, your acceptance rates are going to be high. If you were hovering in the negative before the financial plan is presented, then there is very little chance that they'll pursue treatment. So this game of case acceptance is really, really important to understand, and it's important to kind of structure the whole experience of the patient, the whole initial experience around this, because at the end of the day, we want our patients to pursue the best treatment possible, and the only way they're going to pursue the best treatment possible that we're suggesting to them is if they accept it based on their positive experience. So take-home points from this. The InnoBite to me is number one, a motivator, right? The high bite force situations, they want to reduce that force, right? They don't want a high bite force. And it's a compelling case for stronger material. So let's say they come in, they broke a tooth, they have a high bite force. I'm gonna leave the resins for the patients that have a lower bite force that the material can resist, whilst with you, I would use high strength ceramics, I would use crowns, I would use onlays, so that we give the materials more longevity in your much harder bite. And again, talking about the night guards and more implants in order to mitigate those higher forces. And when we look at patients with lower bite forces, they're going to want to increase those low bite forces. And those are the cases that look at adding teeth. So if they're partially edentulous, they want implants to replace some of those missing spaces. They want implant-supported prosthetics rather than removable dentures. And same with dentures, when they want maybe dentures that are retained by implants that will enable them to have maybe a little bit of a more pre-extraction bite force. So that's really what I wanted to present you with. I know your attention span after a day of work is no longer than this, but I'm going to open this up to Fred and Marianne with questions, and hopefully we'll have some good discussion about things that we talked about.
Dr. Hagi, thank you so much for this awesome presentation. Really, I loved it. We do already have a few questions for you, and I also have some questions that are coming from other clinicians I've met recently outside of this webinar. So, you know, you're just mentioning, you know, for some patient, depending on the bite force, you might be making a different material selection based on the force. And you were talking about resin versus ceramic. Could you maybe expand a little bit on, you know, at which value you would kind of make the switch to ceramic, for example?
So to me, the absolute values are difficult, but I have something that builds into my mind and the way I practice. Everybody has to have sort of a different parameter depending on how they work. But to me, if a filling or a resin is going to have an isthmus width of more than a third of the tooth, and their bite force is high, and I'm looking at 1,000 plus, or in reality, it's about over 900, I'm going to start talking to them about something stronger, because I know that occlusally that tooth is gonna need more support. So I'm going to potentially talk to them about a pressed ceramic, like an onlay, not necessarily a crown. But I want something that's stronger. Now, if we're talking about a second molar in the back and they're having the same bite force, at that point, I want something really strong, right? So at the same bite force on a second molar, I'll start talking about a full coverage crown, about zirconia, things that are not going to chip and break, because everything else under those circumstances are going to. Now, it's a discussion with them too, based on you have a high bite force. I'm suggesting a stronger material, but if that stronger material is not in your budget, right, then the least we can do is protect what you have. And this is where a night guard is going to come into play. So these types of discussions are facilitated with these bite force objective readings, because I can start the conversation. I'm just not just telling you need a crown because I want to put a crown there, right? Like if your bite force was 600, I would feel comfortable putting maybe a conservative onlay or even a resin and leave it on the tooth and see how it does. But the higher the bite force, we do have an argument now to say that these materials won't last as long, right? And it's not the material itself, it's just the way you are subjecting it to those stresses.
Absolutely. Now, let's also maybe expand a little bit. I do see a few questions from the attendees as well, but before we answer some of them, I wanted to talk about Botox, because as you probably know, it's becoming a really hot topic in dentistry, and I wanted to ask you if you ever used it in your practice to reduce the excessive bite force of some of your patients.
I do use it in the practice, sort of injecting into the masseters bilaterally. I haven't measured it, so I don't have measurements after injection with the InnoBite and sort of having more concrete, but there is a definite reduction in the tone of the muscle. With Botox, what happens is there's a reduction in the bite force. There's also more fatigue in them closing down. So it's a sort of a double-edged sword. I find that I'm using it now more in my full arch implant cases at the beginning. So at the beginning, where I'm immediately loading implants and I want to reduce the bite force during the healing phase to prevent fracture of the prosthetics, to prevent implant failure, I find that this is really usable, right? And I am looking at sort of a metric of when I should use it and when I shouldn't. And this is where the InnoBite kind of falls in, because a high bite force, I know that they're more likely to break my prosthetics. A high bite force, I know they're more likely to have issues. So those maybe are the cases where I would use Botox more readily at this point. But I think that in the long term, I think a night guard is a more practical approach. I mean, Botox, you also need to keep, it's a repetitive approach, right? So every 4-6 months, they have to come back, get injected. It's a high cost to doing that. So there's positives when we can control forces for a given application. I think long term, maybe it's not the approach I would use on everybody.
Fair enough. Now, the next question is, do you need to recalibrate the device? So I don't know if you want to take that, or would you like me to answer that one?
You can answer that one from a technical perspective. I think you're better than me.
Wonderful. So the question is no, you don't need to recalibrate your device, your InnoBite. As a matter of fact, the way it's been designed, it's that the software will tell you that you will need to replace your mouthpieces. So that's the blue portion after 1,000 measurements. So, you can take 1,000 measurements at 900, it will let you know. And then we provide you with a brand new mouthpiece recalibrated, and you just plug it in and off you go. You're ready to go and take some new measurements. So that's for that answer. I am looking, Marianne, perhaps there's some
there's
questions
one right
here.
here. So I am RN in my husband's dental practice, and I reduced bite force with botulinum toxins like Xeomin and Botox. What do you think about that?
Yeah, I think I just addressed that. I think it's definitely usable, and it's a good way of doing it. But again, I would tend to use it in the short term. I haven't used it long term, sort of in a repetitive means, sort of for the duration of the patient's life and to see what it does. I do use it though in the short term to facilitate healing in some cases.
And I'm just going to allow myself to expand a little bit on that with further feedback from different users we have. What I've seen, actually, I was in a hospital here in Montreal with a dentist that was treating TMD patients all day long. And he was injecting almost all of them with Botox. And one of the surprising aspect that I found out while I was with him is, we had patients just like yours, Dr. Hagi, with 1,400 Newton, really excessive forces. And then they were injecting them. They were coming back after about 3 months. And then most of them, from what I've seen, and again, that was just maybe 30, 40 patients, could barely apply 400 Newton. So to me, that was a little bit of a question mark, in the sense that I asked myself, are they perhaps injecting too much Botox? Are they perhaps injecting too frequently? And I was thinking maybe measuring bite force could be a way to help with that. I don't know if you have any thoughts on that, Dr. Hagi.
I think that in dentistry in general, the dosage on the masseters, I mean, dentistry medicine, there's sort of a mystery in it. It hasn't been studied as much as the cosmetic Botox does, but on the cosmetic end, we know that the muscles after long-term use really weaken and atrophy. Like there's a feeling. I mean, I've had Botox in the glabella and in the frontalis, and I can say that there is after some use, you do feel this weakening of the muscle. Now, what happens in the jaws after administering 35, 40 units per side? I do imagine that there's a loss of generation of that force, but maybe that's a favorable thing, right? Mm-hmm. How does that affect their mastication? I don't think it's been studied enough to know what happens long term. That's why I'm a supporter of using it for some given application, which is reducing force for a given objective of preventing fracture of a prosthetic or going through an initial phase of healing. But afterwards, I think we have better ways of trying to manage and protect other than just weakening the muscles indiscriminately. In most cases, like some cases are going to require it. Absolutely. There's cases that are like 1,400 and the masseters are here. Yes. But in an average case, I don't see it.
Wonderful. The next question I see is, do you need to sterilize this mouthpiece? And so the question is actually no. I'll take that one, Dr. Hagi, if you don't mind. It's fairly easy. You just have to put a new bag on top of the mouthpiece for each patient. And after you're done taking the measurements, you can just use the FDA or Health Canada approved wipes to clean it up, or your spray. And it's all biocompatible materials. So you just have to clean it and you're ready to go for a new measurement. Marianne, do we have other questions?
I have another question that I got was, who takes the measurements in your office, Dr. Hagi?
So during new patient exams, if I'm using it during a new patient exam, the hygienists typically take the measurement. If I'm doing an implant case, if I'm there, I'm going to do the measurement. I mean, you can delegate the measurement to pretty much anybody. It's as simple to use as anything that we have in practice. It's really putting the sensor between their teeth, obviously putting the sleeve, like Fred mentioned, much like an X-ray sensor, the auxiliaries, the assistants, anybody can be doing it.
Perfect. We also have a question on price. How much is the cost? And I don't know, Fred, if you're thinking that maybe this is when we can introduce our primary distribution partner, Andau, to kind of talk about that.
Absolutely. So Autumn, we're going to try to promote you here as a panelist. And so I'll let you kind of take over and explain a little bit, if people are interested to have more information about the Unibite or did like to purchase one, how does it work, who they should contact, etc.
Thank you so much, Fred. And Dr. Hagi, what a great presentation. So it's an honor to be viewing this evening. We're excited to be the primary distributor for the Unibite product here in North America. And so if you are interested, if you're invited by one of your local Andau territory managers, please contact them. We'd love to have you try out the Unibite, bring it into your practice, show it to your team. If you are joining this evening and you don't know who your Andal territory manager is, then certainly I believe Fred's going to be sharing my information in the chat. You are more than welcome to reach out to me and I can connect you to the right person, be it in Canada or in the US. And then also I believe Marianne will be sending out the CEs. So you're more than welcome to also send her a message requesting more information so that we can contact you. There is some slight pricing differences in the US and Canada. And so we can definitely approach you depending on where you live to give you that. US pricing runs a little under $4,000. And I believe Canadian pricing, correct me if I'm wrong, Fred, I think it's closer to $5,000. Is that correct?
That is correct.
Yeah.
Wonderful. Thank you so much, Autumn, for this. There's more questions. This one, I'm sorry, Dr. Hagi, this is probably one for me. Is the InnoBite compatible with the Mac computer? The answer is yes, because it's not integrated in a computer. So you can, it's a standalone device. So you don't have to connect it to any computer. You just basically have the unit like you saw in the video, and the value is going to be written on the screen. So from there, you can either input it into your patient management software or write it down. So it's really a standalone portable product. Marianne, I think there's more again, right?
Yep, there's another one. So do you take a measurement on every new patient?
We try. I mean, I think our protocols are such that we started taking it on the ones that we thought were the higher forces, the ones that were more at risk. But we're taking it on more and more of our new patient exams. Obviously, not on the children, nobody under 18 really. But on adults, we pretty much try to take it on every single one.
Great. And then can you expand on patient experience? Do they seem to like having their measurement taken, their bite force measurement, and then any responses that they would have?
I think that everything that we've gotten so far has been positive. Obviously, it's new, so nobody's had this before. Nobody really relates it to anything they've had in the past. So with our new patient experience, when we're taking photos, taking the full records of radiographs, CBCT, probing, measuring, like we go through the full gamut, this just kind of completes the picture, right? So we're seen as thorough in every way. We're looking at everything that they have. So it's not just walking in and saying, oh, we see some wear on your teeth. We've actually given them an objective measurement on it. So it's a different, I think they see it as being unique and being innovative because they've never seen it before. Especially since a lot of our patients, once you get to a terminal dentition or fractured teeth, endodontically treated teeth that have been crowned and broken, they've been through the dental system a lot, right? So they know what an X-ray is. They know what to expect. So when something new happens, it's different to them. It's the same as when we scan intraorally, right? And I've been scanning since 2007. To me, it's something old. Like I have a camera, I'm going to take the impression with it. But to some patients, like I've never had this done before. So it's that part of the ultimate experience that helps. So I think the InnoBite is a brilliant, and it's so simple too that it's just remiss not to have this. To be able to kind of to take the practice sort of to the next level on something that most patients haven't experienced before.
Super. That's great.
There's I think another one.
When you conduct patient bite measurements, is this a billable event? Is it billable to insurance?
I honestly haven't really looked into it. I don't think there's any, at least on the ODA codes in Ontario, I don't think there's anything that's billable on it. But if there's something that takes time, I would want to bill for it. But for something like this is literally like a 20-second time investment. The only consumable is really the sleeve that goes on top of the mouthpiece. So I don't think there would be any sort of justification. I think it's just part of the exam or part of the service. It's kind of like you're checking the bite with the occlusal paper. Would you charge for checking the bite with the occlusal paper? I kind of look at it as sort of in the same type of service. It's in the frame of whatever else we're doing.
Wonderful. I do want to also mention that we have some users in the US that are actually using the nutrition consultation code, and that's typically reimbursed by medical insurance. That's mostly useful for people with deficient bite force because they really have a limitation in terms of their diet. So I know in the US, it is possible to do that if ever you would be interested. That being said, I think that is pretty much for all the questions. We provided some contact information to everyone in the chat. So if you have some questions about that, feel free to reach out to us. I think we also have Dr. Hagi's information. I do want to mention also that there is a special promotion we have until the end of this year. And so if you'd like to take advantage of that, you can reach out to Autumn or anyone at Endow. And so we're offering a free mouthpiece replacement. So that's it's a great offer. It's going to be good until the end of this year. Ask us if you have any more questions on that. Marianne, am I forgetting anything here? I feel like
No.
I'm forgetting something.
No, I think we've got it. We got through all the questions. Dr. Hagi, you did a great presentation. Thanks so much. Thank
you. It was good, and I learned something about the nutrition counseling. Being able to bill for it, that's interesting that it goes under that. It's something to be considered.
Wonderful. I do want to thank you, Dr. Hagi. Wonderful, great clinical cases. Always a pleasure to have you. And very informative as well. So if there's more questions, we're going to stay on for a little bit more, a minute or two, but feel free to type them in the chat.
Oh, yeah, just like what you had mentioned real quick, just that the CE credits, I'll be going ahead and sending those out for everyone tomorrow.
Wonderful. So it looks like it's a wrap, guys. I think we're good. So I'm going to wish, in this case, everyone a wonderful evening. And hopefully we'll speak to you soon. Thank you, Dr. Hagi, again, and have a wonderful evening.
Thank you. Happy holidays. Take care.
Thanks.